Okay, I think we'll get started. So I just had a question. You are in the right place if you're here for the addiction care in hospital and inner city settings. That's this session, even though the slide says otherwise. So it's a six different topics that are all kind of joined by this the subject that's on the outline. So first thing first, my name is Trevor Olenek. I'm a family medicine resident from Regina, Saskatchewan. I'm also on the CSAM conference planning committee, and I'm here to help facilitate this topic session this morning. We do have six full speakers. They're each given about 15 minutes each. We'll try and save some time for questions after each speaker. So if you have something riveting that you want to ask, just save it for the end of their presentation. And without spending too much time introducing things, I'll turn it over to the first speaker, Nicole Cowan.
Thank you. Good morning, everyone. I'm Nicole Cowan. I am a clinical nurse specialist, currently working in Vancouver Community Specialized Substance Use Services for Vancouver Coastal Health. And I'm very excited to be here today and share what we found when we tried to apply a modified version of the prediction of alcohol withdrawal severity scale in a withdrawal management setting. I have no conflicts to disclose. I haven't received funding from any commercial interests. Funding for the study was provided by Vancouver Coastal Health Research Institute team grant and the BC Narrowing Gaps grant as well. I also wanted to acknowledge that the research was conducted on the traditional, ancestral, and stolen lands of the Musqueam, Squamish, and Tsleil-Waututh nations. And also, I'm very grateful to be presenting here today on the traditional lands of the Erie, Neutral, Huron-Wendat, Haudenosaunee, Mississaugas, and Anishinaabeg people. So in 2019, it was found that nearly 700,000 Canadians met criteria for moderate to severe alcohol use disorder, and those with regular high-risk drinking patterns may be at risk for experiencing alcohol withdrawal when they suddenly stop using alcohol. And so it's really important for clinicians to have ways to not only identify clients who may have alcohol use disorder or high-risk drinking patterns, but also to be able to stratify risk and be able to match people to appropriate and safe interventions. So maybe clonidine and gabapentin for those who are at lower risk, and reserving higher risk medications like benzodiazepines for people who may be at higher risk, just because we know there are also risk associated with the medication, such as falls, oversedation, increased risk for overdose, and some studies have also found that there may be increased experience of anxiety and also increased risk for return to alcohol use after withdrawal for some folks. So we relied on the Maldonado 2015 pause, which is validated in an acute care setting with very low prevalence of alcohol use disorder and overall low prevalence of co-occurring substance use. They found a cutoff score of 4 or more predicted complicated or severe alcohol withdrawal syndrome, so I'll refer to it as SAWS, with good sensitivity and specificity. And it was incorporated into our high-risk drinking guidelines, alcohol use disorder guidelines nationally, though the guidelines also stress the importance of clinical assessment and emphasis on seizure and DT history. But it hadn't been validated in a community setting or withdrawal management setting yet that we were aware of. And so the study set out to determine if there was an optimal cutoff score that we could apply to our population. And then also through this process, we developed a modified version of PAUSE because item 9, the blood alcohol level, is not readily available in community settings. And so we looked at clinical signs of intoxication, alcohol use in the past 24 hours. And then in our setting, we were able to also use breathalyzer, reading of 0.2 or greater. So from October 2019 to September 2022, there were 228 participants that were entered in the study at Vancouver Detox. So during the time of the study, this was the only resource, bed-based resource, for clients who, when they wanted to be supported with alcohol withdrawal in the VCH region. It's a 24-hour, 24-bed facility that has access to physicians 24 hours, it's 24-hour nursing, and access was primarily through self-referral at the time. It still is, but the major difference was that there was extremely limited clinical assessment prior to admission because it was primarily the screening and referral bookings were done by unregulated healthcare providers. There was very, very minimal stratification for clients. So through our process, we reviewed the charts and looked for key variables. So all clients had the modified pause completed. They all had CWAS scores that we could reference. We looked at the medication that was used for withdrawal, also high-level demographics and relevant clinical history. In our process, we also kept the definition of complicated and severe withdrawal consistent with the Maldonado study. So a CWAS score of 15 or greater, actual experience of seizures or delirium tremens. And then the original study also included symptoms severe enough to require benzodiazepine administration, which in our context, so we would give benzos if the score was 10 or greater, but a score of 10 to 15, we wouldn't consider that a complicated or severe withdrawal presentation necessarily. So I will follow up on that point in a second. So what we found was that primarily most of the participants entered were male, so about 73%. Overall prevalence of co-occurring substance use was very high. It was about 73% of the study sample. And we had almost 26% actually, of people that reported a history of seizures. But during the study, only one progressed to experience a seizure. Interestingly, this client had a pause score of less than 4, had no previous history of stays with us, and no previous seizure history on record. And so we also had about 21.5% of clients that reported a history of delirium tremens. During the study, 9 of those progressed to actually experience DTs. 8 of those had a pause of 4 or greater on all 3 modified versions, and majority had CWAS scores of 15 or greater. So when we looked at the original criteria to determine SAWS, we found that 77% of our folks matched that criteria. But when we removed the benzodiazepine administration alone, we found that dropped to about 28%. And interestingly, in the sensitivity analysis, we used both for applying determining the score threshold, but actually the results weren't impacted. So we found that 4 wasn't predictive of SAWS for all versions of the modified pause. We found the sensitivity was really high, but overall had very low specificity. And then when we tried to use higher cutoff scores, such as 5 or 6, of course, the sensitivity was impacted, and so also wasn't very predictive for all versions. And of course, it's important in our practice to avoid false negatives. We did find that there may be individual criteria that could be more useful, such as history of prior treatment for alcohol use disorder, history of alcohol withdrawal symptoms, history of blackouts, and intoxication in the past 30 days. But all of these criteria, unfortunately, had poor specificity. So we did have some limitations. Of course, we have, clients that's the reason that they're accessing our services, is they're requesting support for withdrawal management. And so prevalence of SAWS, according to original study definitions, was very high, demonstrating potential limited value of screening in our population and the selection effect. But then we have the prevalence that was largely determined by benzodiazepine administration rather than true severe alcohol withdrawal syndrome. And then, of course, there's always going to be a bit of variability in interpretation of pause data and also between clinicians that may be administering the screens. So participants, oh yes, were also treated for alcohol withdrawal symptoms to make sure that they were safe, and anything less would have been very unethical. But some of these folks may have otherwise progressed to experience more severe withdrawal outcomes. And so, in conclusion, we found probably the clinical utility of a modified pause score in the setting and population is low. But what does that mean? It means that our clients are complex. The assessment is very nuanced, and it's important to consider the criteria that are in the pause assessment. Actually, we've been doing this for a long time, and then make sure that we're applying the context and asking more questions to be able to pull that into a risk assessment for our clients. And so it may be helpful to have a lower threshold of 4 in lower risk settings where there's less experience with alcohol use disorder, but this would require more research. And so future studies should explore this area and then also determine if the pause criteria or modified pause criteria with higher sensitivity are in fact more predictive of complicated or severe alcohol withdrawal outcomes. So thank you very much for listening. Please reach out with any questions related to our study or anything to do with withdrawal management. I'm always happy to chat. And we've also submitted to publish a paper, which will hopefully be coming out soon, but I'll keep you posted. That will have more details.
I'll just put it to the floor to see if anyone has any questions about this research.
Useful to do sensitivity and specificity studies on something that is getting rolled out everywhere. So thank you for doing the study.
Great, thank you. All right, any other questions? Sure, yeah.
So I have a quick question. So you had mentioned that one of the challenges that you had were some of the people administering some of the triage aspects at the beginning being untrained. Is there any element of training incorporated?
Yeah, that's a great question. So it wasn't the unregulated healthcare providers that were administering the pause. So we didn't have clinical assessment at the point of referral when clients are calling to access and request a bed. So all of that was done when the clients arrived at the site. So since the study, we've been very, very thrilled that there has been clinical assessment added to that point of access. And it's absolutely critical, especially with how, rising acuity and complexity with our population to be able to determine risk and make sure clients are matched to the appropriate treatment site and medications, and then also prioritize as well who may need to come in urgently. So yeah, it's just been so amazing to see the impact of adding nurses and physicians to that team.
Just for the non-clinicians in the room, can you just define sensitivity and specificity with relation to?
Sure. So this sensitivity, so basically it's going to identify a lot of people in this setting and predict that they will be positive for a severe alcohol withdrawal. So it's going to over-include people. It's going to use an abundance of caution. But what it's not going to do is it's not going to find people who are basically not going to experience a severe withdrawal outcome. And so that's also important to us, because if we have a tool that's just overly sensitive, we're just going to be including a lot of people that also could be matched to other services in this setting. So hopefully. Clear. Okay. Yeah. Oh, great.
That's sort of what you found, because that's actually, the reason the reason I'm reassured by that is that, in the setting where I was, which is in a acute care hospital, admitted to the CWA requires that the patient get admitted to a monitored bed and cannot go to sort of a regular ward bed. So it's actually kind of reassuring that if they didn't need benzodiazepines for a CWA above 10, that a pause of 4 or more is probably predicts that. So I mean, is that fair?
Um,
That's correlated with the pause.
yes, I guess, but it's also going to potentially include a lot of people that actually are never going to progress to require any like benzodiazepines at all at the same time. Yeah, and I would say too, it's important to continue studying this area because it was validated. So depending on your setting, in a hospital setting, this is what they found, and so what we can say is that this is what was expected to find in a hospital setting with lower prevalence perhaps of alcohol use disorder and co-occurring substances and that kind of thing. So definitely we'll err on the side of caution for sure. Yeah. Because that is a big consideration. Yeah. Oh, sure. Thanks.
Sorry if I've cut off anybody else that had some good questions, but we are short on time, so we'll continue on to the next speaker. So I haven't met the presenters for this presentation yet, but the topic is mobile van outreach, providing OAT, harm reduction, and primary care services for people who use drugs in Victoria. So whoever is presenting that one, come on up. All right. Well, it would seem that the person that's been, I'm not giving this presentation, so it's, yeah, moving right along. The next topic is I've got Dr. Brian Conway, Kasim Zafar, and Saina Baitari. Oh, you are here. Okay, perfect. Yeah, I wish.
So as I find my talk, it's a pleasure to be with you here today. I was going to be the third of 3 BC talks in a row, so now I'll be the second of 2. And I'd like to describe some data that we generated earlier this year to evaluate what happens to the hydromorphone that we prescribe as part of the safer supply initiatives that have been in place in British Columbia since early 2020. And this second slide that's coming up is my disclosures. There you go. So so we're going to talk about safer supply and what happens to it in a program that's been up and running since the inception of safer supply in British Columbia, going back to 2020. And these are my disclosures. So the rate of opioid-related mortality, overdose mortality in the first decade of this century in British Columbia was pretty stable at about 200 deaths per year. This is 200 too many. This is human beings. And it began taking off a little bit in 2011. Some people feel that it's coincident with the arrival of fentanyl in our environment. And there were between 350 and 400 deaths in 2014. And then it rose to about 500 in 2015. And when that was realized, that number, 500 deaths, was felt to be catastrophic. And this led to the declaration of a public health emergency in April of 2016. So 500 deaths we thought of as catastrophic. So keep that number in mind. So among the many measures that were taken to address the ongoing opioid crisis in British Columbia, one of these interventions was called safer supply. So writ large, this is really, I'm missing a slide. In any case, writ large, what it was is the prescription of opiates in a way that is not consistent with traditional opiate agonist therapy. So the theory behind that is if we prescribe a specific amount of opiates, and in this case, short-acting hydromorphone being the most common compound, that individuals who are craving the use of opiates would choose to consume this safer compound rather than the more dangerous street opiates that they may choose to buy on the street, and in so doing, reduce the consequences of the dangerous drug supply that is available. So traditionally, this ended up being hydromorphone, and a dose that was picked was 112 milligrams per day, so 14 dilates in the language of the street. And this is basically arrived at a little bit empirically. We had a program of vending machines for a while that dispensed more, as many as 20 or 24 8 milligram dilaudid tablets per day, but this program has since ceased to exist. So it was the prescription of these amounts of hydromorphone with a view to reducing dependence on street opiates. So this program, in a paper that was published in JAMA earlier this year, was evaluated by comparing a number of parameters in the first quarter of 2016 to the first quarter of 2022, so 2 years after the inception of the program. And it's a very good paper. I would commend it to all of you. But among the parameters that were looked at was prescription of opiates increased? Yes, by about 34%. It was still all the same people, so we didn't recruit new prescribers. And if you look at the endpoints, which was hospitalization related to opioid overdose or opioid-related mortality, there did not seem to be any effect of the program on those outcomes, with the caveat that this isn't the only intervention, that this is a very multifactorial process, and that one could still argue that were it not for safer supply, the numbers would have been worse. That's kind of the response that was out there. So it's unclear, although you would have liked to have seen some positive data. So going forward from 2022 to 2023, the situation got worse. We had a record year in British Columbia for overdose deaths in 2023 with over 2,500. And there's a realization that this is a very complex issue, that this is a very vulnerable population with risky drug use that is driven by social factors as much as anything else, including homelessness, and the fact that there isn't going to be a single tool that is going to solve this. And we wrote an editorial in the Vancouver Sun that said, look, this is an issue of people who have no money, no food, no home, and no hope. And until we restore hope and engagement, we aren't going to get anywhere. And there isn't one tool that is going to solve this. It seems that it's getting better in 2024. The numbers look a little bit better, but we will still go over 2,000 deaths likely, remembering that in 2015, when we had 500 deaths, this was considered a catastrophe. In parallel with this, there's a number of reports in the lay press of drug seizures in places where we're trying to cut off dealers that are increasingly finding dilaudid or hydromorphone as the key compound that is being found essentially for potential resale. And you can see that the increase in the number of hydromorphone seizures tracks nicely with the initiation of the Safer Supply program, calling it into question and raising the issue of significant diversion. So this raises questions in our mind. Is the prescribed hydromorphone being consumed as prescribed? Does this prescription of the Safer Supply lead to a change in fentanyl use? And on balance, how can we measure the benefits and risks of this very innovative new sort of intervention? So our program has been in place for a couple of decades, called the Vancouver Infectious Diseases Center. We prescribe Safer Supply to over 200 individuals, and we have stuck with the mantra of 112 milligrams per day of dilaudid, pretty much in conjunction with either a long-acting morphine compound or methadone at a range of doses as shown on this slide, which is pretty pretty standard for what's being used in the community. We now have a facility in the inner city called the Vancouver Urban Health Center across from the courthouse, right in the inner city, that serves as the central area, central place where we prescribe these medications. We have 4 peer workers that link us to the community, and a very open policy in terms of accepting new patients. Now, in this center, and it's really important to understand this isn't just an addiction clinic. We are basing our program on the 4-legged chair. So we provide attention to medical needs, social needs, addiction needs, and mental health needs with a team of doctors, nurses, and peers. So the addiction program is embedded within this multidisciplinary offer of care. And it's based on 3 pillars. So the goal is engagement, then multidisciplinarity, and durability. So to take someone who's disengaged and engage them in care, make sure that it attends to all of their needs in a dynamic way, and that this is a long-term program. It isn't just a one-off intervention. So what we did in March and April is we took 50 individuals who were enrolled in our Safer Supply program. We made sure that they had picked up their hydromorphone that morning. They were all daily dispensed hydromorphone. We had the medical appointment occur without knowledge of the result of that day's urine drug screen, and a decision on the represcription of hydromorphone was made. After this had occurred, they were taken somewhere else, and a member of our research team that had nothing to do with the clinic itself or the process of evaluation of the patient administered a questionnaire to collect demographic and behavioral information. The urine drug screen was then done, and all of these data form the analysis that we have since conducted. So the key question, and we divided this into 4 things. Hydromorphone, did you take it? Do you take the pills, all as pills? Do you take all of your hydromorphone, some as pills, some by other means? Do you take some of your hydromorphone and do something else with the rest? Or do you take none of your hydromorphone? So this first analysis to this question, and the question was asked independently of the process of prescription, as I've said. So 2 people in the questionnaire said that they took no hydromorphone. 10 said that they take some and sell or trade the rest. 31 said they take all the pills, and 7 say that they take some as pills and some by other means. So if you make 2 groups, 38 individuals that say they take all the hydromorphone as pills or not, and the 12 others, you look at the data, and basically those that don't take the hydromorphone, in terms of the questions, they tended to be younger, they tended to inject more, have more of a history of overdose, be a bit less stably housed, have a lower likelihood of higher education, and all were unemployed. So that gives you some, you think it gives you some idea. But let us recall that we did urine drug screens, and 12 of the 50 were flat out negative. All of the others were positive for street drugs, and 85% positive for fentanyl, and none were negative. So you would think, okay, so these 12, it's going to be the 2 that said they were taking no hydromorphone, and then a few others going up the categories. And if you try and look at the data that way, it was random. So 5 of the people that said they took all their hydromorphone as pills had a negative urine drug screen. So it is very random in terms of how it is sorted, in terms of there's no characteristic that we could identify. Oh no. Did we? Oh, then this is totally my fault. We loaded the wrong version. We worked hard. I will take responsibility for that. Okay, before I get to the conclusion, there's one key slide. We looked at the number of overdoses that occurred in 2023 and 2024. So you'll have to follow. I remember the data because I just looked at it. So of the 50 individuals, 10 had medically significant overdoses that generated a record that we could find on a program called Care Connect. So there was an emergency admission. So 10 of the 50, so 40 did not. We looked at the association between likelihood of overdose risk and hydromorphone consumption versus non-consumption based on the urine drug screen. No association. It was 20% in 18 and 23%. We looked at methadone. As in methadone, it was 10% versus 25%. So if you're on methadone, it seemed to protect you against overdoses. However, this is not a randomized study of methadone versus Cadian. There may be something different about the people on methadone that keeps them on methadone that makes them make better or safer decisions about their drug use. They're the ones that aren't asking for Cadian. And so there may be a different population altogether. So in conclusion, a quarter of the people to whom we prescribe hydromorphone do not seem to take it. There is no behavioral correlate of this. There's little effect on the qualitative use, yes, no, of fentanyl. Is there a quantitative, or are they using less fentanyl? They're overdosing less often, and I should tell you that none of the 200 individuals that are in our Safer Supply program have died of an overdose in the past 18 months. So this is potentially a good thing. So what do we do with this information? And I think these are the questions we have to ask ourselves, especially in the setting in Vancouver, where what we're seeing is people getting cut off from their hydromorphone for having a negative urine drug screen. And we need to have a concerted policy to address this. And I look forward to a few minutes of questions. But first, I will tell you that our program survives on having many commercial and non-commercial partners, allows us to do our work, and we're very grateful to all those partners. Thank you very much.
Okay, thank you very much. I'm going to open up the question. Yeah, we've got one here first. You can just stand up and ask it, or there is a microphone there if you need.
Sure. Okay. So, Adam Zivo with the National Post. So I noticed in your digital poster presentation that 84% of the patients still use fentanyl.
Yep.
Despite being on Safer Supply for games last 2 months.
Yep.
Would that suggest that Safer Supply is ineffective at dissuading people from using illicit fentanyl? And do you have any evidence that your patients reduce their fentanyl use aside from patient self-reported data?
We have the only evidence that I would present to you is that the number of medically significant overdoses is less than what we would have expected, and we have not experienced any opioid-related mortality in our cohort. And I think that the Safer Supply program, some may have wanted it to be the solution to the overdose crisis. It's a very complex situation. And I think if we think of it as a tool that might be helpful in some settings and understand how to use it and how to adapt it on an ongoing basis in individual patients, I think that's where it will find its maximal utility.
And then you at the back there, you had your hand up first.
Well, we've just kind of learned that there's probably quite a bit of diversion, and it's not a hydromorphone so much as the oxycodone. So one of my questions was, it doesn't look like you compared or did a study where they were saying safe supply using oxycodone, so that's one kind of comment. The other is, were any of the doses of the hydromorphone witnessed, and did the clients have to come to the clinic daily, to the pharmacy there, or did they go to they didn't go to a community pharmacy, right? So, and then part of that was just I didn't know how you mitigate, like maybe in this here at the clinic you're at, where there's people waiting outside the pharmacy to buy drugs, probably.
There's about 5 questions in there, all of which are excellent. No to oxycodone, daily dispensed, either they come to the pharmacy or it is delivered. There is obviously the issue of people waiting outside pharmacies and outside buildings to purchase a hydromorphone. They know when the delivery guy comes, and that's sort of a fact of life in these kinds of programs. Did I miss one? Folks, you mean the clients, the patients? Yeah. Well, again, the philosophy of our program is that we'll take care of your HIV, your hepatitis C, we'll fill out your welfare forms, we'll connect you to mental health, we'll do all of those things. There are people that do all of that, and addiction care is delivered in that context. So I think that's kind of maybe a bit different than some, it may be the interpretation of what happens with what's prescribed may vary based on the context where it is prescribed, I guess, is what I'm trying to say.
Lots of questions. Maybe you with the scarf there. Sorry. Yeah.
Any of them on?
Any of them on a backbone and
Oh, yes, all. All. We don't do dilaudid. Actually, if I didn't make that clear, we do not do hydromorphone alone, ever. 50% were on methadone, which is where I got the methadone data. So I'm sorry if that I loaded the wrong version. That's on me. But yeah. And Cadian is the other the other one that is used. A long-acting. Well, Sublocade. We wouldn't have someone on Sublocade and Safer Supply. I wouldn't do that. You do. Really? With hydromorphone? Okay. I would have to think about that mechanistically. Okay. No, I think again, there's no one size fits all. I think that's one thing I should say. Lynette raised her hand real quick, and
About, you didn't have the slide up, but that can incentivize people and lift them out of poverty and help.
oh boy.
So the lack of death rate can also be due to improved lifestyle and health related to more money through diversion, not getting shot by your drug dealer because you're paying, selling to them instead of from them. So it's a complicated issue.
Oh, yeah. Well, just on the money thing, what I prefer to do, and this is that's why our program does that, is most of these individuals should be on disability from the province, and many would deserve the monthly nutritional supplement. If you do that paperwork, their income goes from $650 to $1,500 a month. If someone does the paperwork. Yeah, they can get more money more quickly than that. You're not wrong. Yeah, but on the money, that's sort of how. But you're not. But what you just said is not wrong.
Okay. I think one of the earlier ones was, yeah, you at the back with the sort of, yeah.
Hi, Brian, David Marsh.
Hey,
The urine results that you quoted, are those immunoassay? Because it's quite possible to get false negatives with hydromorphone immunoassays.
They are, and I don't know of the cutoff. So you're saying, but what would be? I don't know the threshold of the test. It's the available urine drug screen for hydromorphone. That's all I will say. So do you know the cutoff? Like if you took 1 8 milligram hydromorphone, it would still be negative, maybe? I don't know the cutoff, but we rely on them for everything else, right?
Yeah, if they're positive, they're positive.
No, but if it's negative, you're saying I didn't take enough hydromorphone?
They may have taken it all at once 24 hours ago.
Well, this is why the way we did it is they picked up in the morning. All of I should have said this in the slide. All of the recruitments were early afternoon, like from 1 to 3, and they picked up their hydromorphone in the morning. We made sure they picked it up. None of the doses, that was the question. None of our doses are witnessed. They just pick up their hydromorphone. So I don't know. That's as close as, but your point taken.
And there was, I think we have room for just a couple more questions, but the gentleman just behind the, yeah.
Given 25% diversion rate, just looking at this myself, I work in outpatient OT clinics, inpatient. Isn't this very clear that we should not safe. I mean, 112 milligrams a day of hydrochloroquine, over 600 milligrams of morphine. We know opiates are not safe. We have evidence from the early 2000s that the oxycontin epidemic. We were just ravaging the streets with more opiates. There's obviously the financial incentives for people to divert. And now we're seeing the number one cause of pediatric patients of 13 to 18 is opiates. Now the argument is saying they're dying of fentanyl, but they're not starting with fentanyl. They're starting with Dilantin. And I see tons of patients that are coming in that are waiting outside the pharmacies that are kids that have no idea they're taking an opiate. They're just taking a dilly. And so it's pretty concerning when we're seeing those numbers. We already have evidence that opiates aren't safe. And we don't even see mortality benefit because that's attributed to their OET factor. That's not from the safe supply. That's from their methadone, or potential self. So as a physician, I'm looking at this saying, how are you not doing harm? Because that's pretty freaking concerning.
So quick answer. I mean, again, I don't, the reality, this is a very difficult topic, okay? And we embarked on this analysis knowing that we'd probably satisfy nobody with the answer. But here's what I would say. In terms of the dose of hydromorphone, these are by and large individuals that use gram quantities of opiates on the street. And so in terms of their own personal toxicity, it's, it's limited. Okay, well, again, see, the diversion piece is what we need to understand. And yeah, there are cases, I heard from the BC Children's, as teenagers come in, they come in with somebody else's prescription that they haven't, the name hasn't been taken off, and they still have the bottle of Dilaudid. So, I mean, I'm not saying that it's completely safe to the entire environment. Discussion we need to have. And in terms of whether to do it or not, many of these individuals are completely disengaged from care and are doing whatever they want, whenever they want. And these are the individuals at the highest risk of dying of overdoses. So doing something that creates engagement and working forward from there, there's something to be said for the benefits of that. Well, this is why on my, don't put it up again, but I said we need to weigh the pluses. This is not all good and all bad. This is something that we need to talk to each other and have the conversation as opposed to, and one of the main things is people have said that this doesn't work. And the people that say that sometimes is they thought this was the magic bullet, it would solve everybody's problems. I remember the mayor of Vancouver said, well, now we have safer supply, we're okay. And that's an overstatement. So maybe one more and I'll, well, you're the chair, I'm sorry.
So we are kind of running up on time. I'm going to ask or allow the opportunity for one brief question. I know that you've had your hand up for quite a while. Sorry.
Somewhat, the questionnaire was anonymous, didn't capture the urine drug screen till later. It sounds like you were surprised with the findings. In that same time frame, were you able to compare it to, another 50 that you would ask the same questions to, that you would gather the urine drug screen, etc., and do a bit of a comparative analysis? That was over 2 months, I think.
Well, it was to recruit 50. It was in March and April. Yeah, I think this is we have many other individuals in the program, and we're looking at different analyses and collecting more data to move forward on this. It's complicated. It looks as if the questionnaire wasn't answered. You would have thought people. We went to great lengths to try and get an honest answer, and it didn't. Even that didn't seem to generate the the honesty that we would have liked. And honesty is a value word. I take it back. We were looking for the facts, and I didn't necessarily care, but we need what the answer was, as long as it was the answer. So there's a big discrepancy between the UDSs and the questionnaire, and I got to believe the UDSs. That's with Dr. Marsh's comments taken into account. But I think. Well, that is my program, or our program. Oh, I see. Did the research itself influence the rate? I could look at that. I could look at that. Because we collect urine drug screens. That would just be I'd have to look at it. Thank you for that.
Okay, thank you very much, and thank you for all the stimulating questions. So our next presenter is speaking on the transitioning inpatient experiences, community-provided complementary supports for perinatal substance use services, and this is Darcy Skyber.
Wow, so I got the short straw and had to follow a prescribed safer supply. That's great, thank you. I say that, and I mean, I could talk about this all day. I was like, how do I get out of doing this? I want to talk about that because I'm currently also completing my PhD, and it is related to the when we deprescribe, what happens to all those folks. So this is a topic that is also very personal to me. But I will focus on this one now. That's probably less exciting for many of you in the room here. So my name is Darcy Skyber. I'm the executive director at BC Women's Hospital, and I support all of our mental health and substance use programs that we offer on site. And then I also lead our provincial perinatal substance use program. And so in that, we act as a bit of a funder. I mean, a large funder actually across the province, and we support all kinds of programs and services that offer, bed-based, ambulatory or outpatient programs, doing research, et cetera, related to perinatal substance use. So really love that work, and it allows us to kind of keep our pulse on what's happening out in the community. So here we go. Okay, so I have no disclosures, but this lovely photo of our amazing team at BC Women's Hospital that I wanted to share with you all. And I wanted to do something different with my land acknowledgement today. So we just hosted our annual provincial perinatal substance use conference a couple of weeks ago, and our amazing project manager had this great idea to start a bit of a Slido conversation throughout the conference to engage people in a few different topic areas. And one of the questions that we asked folks was related to, describe or identify a word that comes to mind for you when you think about, the lands that we are privileged to kind of work and play on, and the people who steward them. And there were so many great words, and I was really struck by this. So I basically, they sent me this Slido Excel document, and I was reading through it, and the conference theme was around connecting the dots and how do we sort of, as a workforce and also as care providers, connect to one another, connect to our patients, our clients, and our communities. And what I started to think about is, wouldn't it be amazing, and what would be different in terms of our systems of care if the people that we served started to describe our healthcare system with words like this? And so I use this just as a way to kind of poke people to think about that, because it just really struck me. And I think if we could actually sort of emanate that in the work that we do, like that is, in my mind, a real acknowledgement and a commitment to reconciliation. So I just wanted to kind of throw that out there for folks to think about. So the objectives today, a couple things that I really wanted to focus on are, a few different pieces that we sort of did, like in terms of programs and services that we brought to our campus. But then also I wanted to talk about the barriers and the challenges that we experience both within our workforce, but also within the system that we work within, because it's, I'm the executive director. There's, 3 levels of senior leadership at our hospital, and I'm the only person across the entire leadership team that isn't a nurse. So I come to this work, both as a woman with lived experience, but also as someone who's worked in community in mental health and substance use for 20 years. And so I have no idea how I ended up in the largest birthing hospital in the province leading, but here I am. But when I came to the hospital, I was just really struck by, how, and I think it happens because it needs to, but, when you're working in an acute care space, you tend to really, we focus on pathologizing people and diagnosing people and assessing people and then treating people. And it is this very sort of often linear process. And when I came to the hospital, I started to really look at, are there other ways to kind of do this and bring in not only the the patient voice a little more, but also what happens out in the community. Like oftentimes there's just this magic that happens. And even, the previous presenter, when you're talking about that four-legged or the four-legged chair approach, and I'm like, man, like if we could do more of that, even in acute care spaces, what a shift. So that was really, my vision for the portfolio was to really look at how we kind of move away from just, pathologizing and just treating from a medical perspective the patients that we're serving. And so there's a few different initiatives that over the last 3 years that we've brought on that I wanted to just highlight for folks. So the first one is acupuncture. And I mean, I think in community, most of us that work in substance use are very well versed in the, acupuncture being in detox spaces and, bed-based treatment spaces, and even like, community health centers. And so we brought that onto our FIR inpatient unit. And for folks that aren't aware of FIR, it is the only program of its kind in Canada. And it's, we work with women who are currently using substances or attempting to not use substances who are pregnant or parenting. And so we get folks from all over the province, obviously very, complex patients that come to us. And so acupuncture was one of those things that when it was first introduced on the unit, our providers and our nurses and our administrators were like, quite terrifying. And a lot of those conversations around it's not necessarily a sort of regulated profession within an acute care hospital space, and where's the evidence to actually support that this is going to be beneficial for our patients, but also that we're not going to do harm. So we had a fair bit of work to do to really make the case to bring that in. And I will say that, the patient experience for FIR is amazing. The acupuncture program that we have on FIR, we've had to double the amount of time that they provide that care to folks on FIR. It is the most well-attended program that we have on FIR in terms of any of the allied health programming that we offer. And over the last 6 months or so, we've actually been asked to expand it. So now we're doing it within our kind of maternity, birthing, postpartum spaces. And, just last week, I had an ask from the staff, just because the patients that we serve are so complex, the staff are asking if there can be a space for them to get acupuncture as part of, regulating their own nervous system as part of the workday. And so we're just working on, getting consent and risk, legal, all that stuff approved to be able to bring that in. So it's very exciting, and like I said, the patients love it. The next one that we've been working on is our patient and family advisor. So, like I said, I'm a person with lived experience, and all of the work that I've had the opportunity to lead across the province over the last 10 years or so, I have been really focused on making sure that the voice of people with lived and living experience is sort of embedded in any of the programs and services that I design. And I will say that trying to do this within an acute care space was most difficult. Again, we come up against this, the barriers around, well, they're not a regulated profession, and they can't have access to our electronic charts, and they shouldn't be sitting in spaces with physicians and hearing, complex medical information. And so there was all of these barriers when I first, started talking about bringing a PFA team into the campus. And then you have all the kind of, the larger sort of systemic stuff within the organization. Folks that have lived experience often come with lived experience, and even just working with our, talent and acquisition and our recruitment, to say criminal records shouldn't be a reason to not hire someone when you're wanting them for their lived experience. And so had to do a lot of work with our kind of more corporate systems to be able to push that through. But I will say that, our leader for that team is here, and you guys will hear more about this particular piece of work that we do later in the week, because we're presenting on that here as well. But it is absolutely my favorite, and I think it's interesting to me now, 2 years in, to see that everybody wants the PFAs now, right? So we're kind of in this position where it's like, okay, we keep adding more, but we also need to get really clear on what your work is, because you can't be sort of everything to everyone. And so it's been a very interesting transition in terms of being able to kind of win over the team and build that trust within. And we'll talk a bit about that too. So the last one was an overdose prevention service. So we did a pilot, and this is kind of I will say, as a leader and an administrator, I have found the best loophole to be able to introduce things that aren't necessarily mainstream in acute care is to just call it a pilot, and then you're able to get it through. So I do a lot of pilots in my portfolio, and then I just quietly remove the word pilot, and then it becomes part of the program. So we brought an overdose prevention service onto the campus, and I will also say, and I'm saying this, being a bit cheeky, but as a healthcare leader, you haven't really lived until you've tried to bring overdose prevention services to a birthing hospital and a children's hospital, because it was an uphill climb, that one. But for me, it was when we started looking at with our FIR inpatient program, and like I said, we're a provincial resource, and so often we're bringing folks to Vancouver who have never been in Vancouver. And where do people go typically to use substances in Vancouver? To the downtown east side. And so what was happening, and what I started to notice, was this pattern of we were losing our patients because they would go and try and access an overdose prevention service in the downtown east side, or get their substances in the downtown east side, and then we would lose them. And so it becomes this, so now we've separated a mom from her babe. We have entered this family into the child welfare system because we're not connected to them anymore. And then we're also destabilizing our patients. So our thought was, well, what if we just brought that service to the hospital? Yeah, it was rough, and a lot of learning. And so a couple of things for me that I noted on the slide there. Very interesting learning, and I think as we start to actually embark on bringing a fixed service to our campus and some EOPs, we really want to be mindful of that, because there were some real issues in terms of we had this overdose prevention service on the campus, but it wasn't part of our campus. And I was quite intentional about doing that, because I wanted to make sure that there was a separation between what was happening in that space and that our folks that were accessing it were protected in terms of their privacy and their confidentiality. But that didn't translate to our patients, right? So they still felt like this site is here, and oftentimes I'm going back to the unit, and the nurses on the unit might know that I access a service, and are they going to put that in my chart? And so we had to do a lot of work with our team, even around, if our patient left our hospital and went into the downtown east side to use substances or access an overdose prevention, would you put that in their chart? And so what we learned was, well, no, they wouldn't, because it is this sort of out of sight, out of mind. We can't actually guarantee what they're doing. And so a lot of education with our team around that distinction still needs to be there, even though the resource is sitting right here. So we would do that differently based on the feedback that we got from our patients and our partners and families that were accessing. And then, like I said, I kind of said it joking, but some real limitations in terms of access to this resource. And I think I can't even see my own slide. Right. So I was just talking about we're so risk adverse in healthcare systems, right? And so it was interesting to me as I was looking at the data and the feedback we had feedback from staff across the site after we wrapped up the pilot, and we had feedback from the patients and the folks who were accessing the service. And there was this real discomfort, I'll say, with having the service there and not having that kind of oversight over it. But I was, when we wrapped it up, I'm like, I'm not really sure how we would fix that. And I also want to make it accessible. And so when I had gone to the administration and said, it'd be really great if we could just open this up to the community around us here. And it was really a hard no, right? There's still this stigma that we're perpetuating in terms of we're not able to talk about overdose prevention services in an acute care space as just another healthcare intervention. And so definitely some work to do there as we start to kind of build that out moving forward. So these are the sort of like key takeaway for me. Sorry, I'm half blind. Um, so I think anytime I introduce a pilot or we're kind of adding new programs or services, I always try to think of or to evaluate it with sort of three different lenses. And one is like, how is it impacted or affected or increased patient experience? The other is how is it, impacted, affected, or increased satisfaction with our workforce? And then the other one is what are the impacts and the, effectiveness related to our larger system? And so lots of learning for us in terms of bringing all these services on. And I would say the biggest one for me as the, sort of administrator is the barriers that we face within our hospital system as a whole in terms of being able to, really get comfortable with services that are more community-based in an acute care space. So, I'm getting this now. God, I thought I was talking so fast. So, I mean, I'm happy to kind of chat with folks more about this too. Like I said, there's another presentation later in the week related to some of this work, but I just think it's really important, and I say this again as someone who's completely biased, having come from community, not a nurse, but now in acute care, that I think there are real opportunities to look at sort of non-traditional provider roles within acute care spaces. And I'm done, thanks.
Okay, we are a bit tight on time, but if anyone has one question, we can ask one question. Okay, yeah.
There's great question. We're looking at actually a fixed space right now. So we're looking at a fixed space and also EOPS to be able to kind of accommodate both populations. But yes, it is absolutely coming back. Yes. Yeah, not a pilot. Remember. Don't tell anyone I told you guys my hack, okay? Thank you.
All right, thank you very much, and hopefully we can all take that advice and call everything a pilot from now on. So our next presenter is Nathan Gardner, who's going to be speaking about the Mission United Hub.
Thank you so much. I thought I invented the call it a pilot routine, so it's good though. It's good. I'm glad other people are having like-minded ideas. I also want to apologize. I realize I am speaking at a medical conference and creating the absolute faux pas of recovering from a cold post-COVID. So apologies for that. But my name is Nathan Gardner. I represent a small charity in Oshawa called the Backdoor Mission. I'm the executive director there. I'm here to talk to you today and tell a little story that, although I say on a slide, it mentions approach to care through the COVID-19 pandemic. It's more so really a story of how we utilize the COVID-19 pandemic to build and design an approach to care for homeless individuals that we always knew was something that was needed and as grounded in community. Am I pointing it the wrong way? Oh, no, there we go. Pointing it the wrong way. Perfect. So I want everybody, and I realize again, just in a room full of healthcare professionals, I don't want to traumatize everybody, but if you can, please put your mind back into March of 2020, just for a second. Of course, everything shut down. Everywhere, everybody was trying to decide what to do. How do we manage this from hospitals, from social service side? I deal and we work within homelessness and systems planning. And so the one thing that came to every small municipality, every social service agency, we were told shut down, go indoors, go virtual, go over the phone, do whatever you can. But what does that mean for the NFAs? What does that mean for the homeless population? How could you possibly provide care, service, anything to individuals who are living on the street and don't have anywhere to hook up to a virtual session of any kind? And so what we did as a small group was, of course, first we panicked, and then we started talking to our networks and groups, and there was really no definitive, here's who you go, it's public health, it's someone with your regional or local government, what is the province saying, what are the feds saying at this time, who knew? And so we went to those people who were trusted. They were frontline workers, nurses. In my case, I was a systems planner that did a lot of research. And we said, what can we do? What's available? And really what we decided was there were places in our community that our populations went to that would be willing to stay open. For us, I didn't work here at the time, but it was a small church known as the Backdoor Mission, which was a program located at the Simcoe Street United Church, has been a program since the late 90s, which really offered meals, respites, small amounts of navigation, $50,000 a year budget just to provide coffee and muffins for the most part. And what that church and that group of people said was, mainly volunteers, I should say, yes, we'll open, we'll do whatever we can. We created, our plan at the time was to create things called hygiene hubs, which we realized about a week later was probably not a great term, but whatever, it was the pandemic. And essentially it was places where homeless individuals could come and test for COVID, stay clean, wash themselves, try to stay as safe as possible at the time. And they were set up outdoors, eventually moved indoors. We called on partners like the CMHA Durham to help provide small amounts of primary care. We had an NP that said, yes, I'll do COVID screening. We had a nurse that said, yes, I'll do whatever's possible. And a physician that did a rotating intercity health team that said, I'll come on and give what's needed. We set up a shed, a literal shed out in the parking lot where we did COVID screening and testing. We had, I call it the worst job in Ontario. We had a screener who basically intook people through the door and said, what are your symptoms? And if you screen positive, go to the shed. And we had a group of people that tried to keep people fed. We eventually tried to give people rest areas. We tried to give people sleep. But for the most part, we tried to provide care to individuals as much as possible. What we found very quickly is we were there to provide a COVID service, but less than 1% of our clients, we actually refer to them as patrons, were coming for COVID reasons. They were coming in to get access to primary care. We had nurses and doctors on site. We had people who were suffering from, I always ask our staff, how many people do you think of our clientele suffer from mental health and addictions? They say, Nathan, what number is bigger than 100%? And so they were coming to provide access to food, shelter, but also those services that they just couldn't they couldn't find, not only in a COVID world, but in the reality in their normal day-to-day lives. Ooh, this is a video, so we'll see if this works. We have sound? That's okay. The visuals are stunning anyway. So if we can at the end, maybe at any time you can come to our website. I'm really proud of our videos, so you can look through our videos, and it shows a little bit about what our site looks like, and of course me clean shaven for once. So what we actually did on site was we brought in all of our providers. CMHA Durham was the first organization from a primary care level that said, yes, we will do this, we will participate, we will come, we will mask and gown, we'll do everything that's needed, we'll see these people where they're at. And we started asking all those other providers, and we began to co-locate. So of course, you see on there, I've sectioned it off to both the service and as well the provider that's on there, which is really important because all of these individuals, all of these organizations, some of them you'll recognize as big, national, like CMHA and the John Howard Society. Some are a little different. ACDR is the AIDS Committee of Durham Region. CDCD, Community Development Council Durham. DCHC is our local community health center. All of these agencies provided supports, housing supports, case management, crisis outreach, victim services, which is a huge one. They all came on site. They said, yes, we will co-locate. We'll sit a small little booth in a 160-year-old church, and we'll try to give service to people there because that's where they're coming, and there's a pandemic going on. They came there for the pandemic, but eventually what we found is they were staying because they found a different care plan, a different model of care that was existing in Oshawa. So what you see here, of course, is these are actually our titrating beds. These are not just medical or care beds, but these are where individuals will actually titrate daily on methadone, Suboxone, anything. I should have actually note that my clinician NP, Stephanie Skopik, is not here today. So if you have granular medical questions after, I'm going to have to point them to her. And as well as our safe sleep area on site. But what we found about those people coming on site and responding to a crisis was that, again, there was something more. They were actually receiving something more out of being co-located than just providing their service in the same space. So I like to refer to it as we did not create a strip mall. There was not housing services, financial services, primary care services, crisis services beside. But actually, we existed in a market where you could look over, you could talk to your neighbor, and the term referral is extremely funny to us because referral means, hey, John's over there, why don't you go see him? So what was actually born? Oh, a little bit's cut off, but that's okay. What was born was an approach. And so what we asked those individuals to do is to join into an approach to care. And for us, that meant, as you can see, of all these things that are here, the most important, right up top there, where it says, if we engage in people first relationship development that is rooted in our approach and values, then all the other great things will happen. So what we found is that every person that came in had to first build a trusting relationship with all the individuals on site. That was extremely important. And what we found was that if you built relationships with the clients, then you were able to provide more access to their care later on. People that would come in for meals, they would then end up getting access to treatment services, to crisis services. We grounded this in a clinical rounds each day. It's something that developed organically. People began meeting at the beginning of this ordeal of the pandemic and saying, what do we got today? And then we started talking about clients. Who do we see today? What does this person need? And then what we realized is that we were creating individual care plans. And while in a hospital setting or in a clinical setting, usually that care plan in a rounds would mean, what medication somebody's taking, what's next, do they have surgery, what acute or chronic needs are being met on that day for that individual. For us, it also meant what's going on in the relationship. Do they have a parole hearing? What else is going on in their lives? What have we heard on the street? And most importantly, paying attention to different types of batches, colors, doses, how that was affecting individuals, knowing what each individual took, and knowing their status. So the part of that care plan, which was really amazing, by having different co-located institutions, organizations on site, I have actually seen where an individual has come in looking for some type of care, usually a primary care setting, in one day, in a 30-second round, because we have everybody there sitting on their computers, on their own individual systems with different legislations and different unions represented, we're actually, a doctor might say, I want to, we have to, no identification, no access to OHIP, no access to financial services, no home, no care plan, no whatever. All of those things, OW worker, yep, I know them, I can get you that. We have a John Howard outreach worker today. Okay, if they come in, we can see them, we can get them their ID, we do ID clinics here. OW is also on site. Yep, we can make sure that their financial is up to date as long as they come in. We'll be able to take care of that. And so what used to happen in the old setting, in the old service, was, again, that dirty little word, which we refer to as referrals, but that didn't happen. It was actually care plans taking place on site. And so if you think about it, the approach that we created was 100% low barrier. An individual comes into our site, and they may be able to come in looking for a meal and looking to get off drugs. They can actually do that. They have access. They can go through on a single day. They can get their meal. They can have a safe sleep area in one of our spaces, and then they can see a practitioner that day. In the same day, they can actually virtually get access to an addictions physician, get their script, get titrated on site, and begin that titration, begin their withdrawal management program, potentially 15, 20, 30 minutes from the time they came in and said, I need help. We do that in a community setting. We also do that because we build that relationship with that individual. They might have been coming back for years. They might have been coming back and known about our location. But this time they're ready to say yes, and we're able to make it happen that day. And we do so because as a shared group, and again, this is something that 10, 11 different organizations have adhered to. We believe in one really, really important principle that provides accessibility and provides that low barrier approach. And it's something that from a social service standpoint and a medical standpoint, I know is rooted and binds those two sectors together. That is extremely important. Does anybody know what that is? What's the thing that binds hospitals, healthcare, social services, Ontario Works, financial welfare service? What's the thing they all have? Anyone want to take a guess? They do have clients. That's true. They do have clients. There's probably more than one thing. I've broadened that out a little bit. But to us, there's something that we saw in similarities that every one of those institutions, for the most part, has that we never. Not only do we not have, we actually vehemently oppose and don't believe in it. And that is appointments. We never say to an individual, "See you next Thursday at 2 o'clock. When we refer, it's that day. It's what we can do with the individual. And when I say what we can do, it's not just based on who's here today. Is John Howard off because they're short-staffed, or do we actually not have that care provider on site, or whatever? It's the individual's cognitive ability to be able to function and do whatever they can in that day. We know with our clientele, we have honed in on a clientele that is as we say, for the most part, has the comorbidities of chronic homelessness, psychiatric conditions. We don't use the term mental health because almost all of our clients are suffering from some type of psychosis, and substance use disorders. So those individuals, if you can imagine, on any given day, depending on what's gone in their element, or what they've taken, or any other number of cases, what medications they haven't taken, they could have a different ability to actually function and perform. And that means, if you have an appointment at an OW office to get your your rent sups together, and that day was not a good day for you, then you got another month to wait. You're on the street. You're back at it. In our location, we do whatever we can that day. So it could be getting 9 things knocked off that may otherwise, not been done. And the beauty of our location, and I'm going to point to my last slide here, which is our results. These are just some basic stacks from 1 year. This is our 23-24 stats. But the beauty of our results, if you look at all those things, the medical the medical data that we have up there is all basically from CMHA Durham or from Lake Ridge Health. They do have one worker on site. Ontario Works, Victim Services, our housing support workers, and our meals. All of the services that you saw, I shouldn't say all, but most, they exist within a 1 kilometer radius of the backdoor mission of Simcoe Street United. So think about that. These individuals had at any given time the ability to walk down the street and do all of the functions and take care of all the care plans that they could have possibly enjoyed at any given time throughout their journey, but they didn't. And we know that's because we created that approach to care that's rooted in community, in equity, and respect for the individual, that values them and values them as an individual, and values their choices and their struggles. That is why they've continued to come back, and we've created a sense of community in a space, and we've integrated those necessary care plans and those care needs, really rooted in primary care and addiction services as much as possible, into that setting, rather than the other way around, rather than trying to onset community into an already clinical setting. We've kind of turned it on its head that way. So I will wrap up. Our next steps, we are working on a logical treatment continuum that is really based on eliminating. If you look at all these steps, there are probably things that are not unique to anybody, but for a homeless individual, our approach is really rooted in removing the gaps from each one of those steps. So, is there any questions? Please let me know. All of it. I mean, it's you guys can hear me okay? I'm a teacher by trade, so what the hell. I mean, it has developed over time like anything. At the onset, it was mostly methadone, Suboxone. They did suffocates. Hydromorphine not as much. I know that for sure. But basically, as we looked for a hospital setting level of withdrawal management in a clinical setting. So whatever the needs of the client is, we have the capability and ability to do so. I stopped outside.
Okay.
The actual breakdown is a Stephanie question, but basically all.
Okay, I think that's good. All right, thank you very much. We have just one more presentation, evaluating a transitional housing program for people who use substances who experience homelessness and mental health. Give you 5 minutes and 2 minutes.
Okay. Hi, everyone. My name is Kristen Morin. I'm a researcher
these are my co-presenters. Jada Carter is a peer researcher and peer consultant for some of the addiction programs at Health Sciences North in Sudbury, Ontario. And this is Dr. Tara Leary. She is a addiction medicine physician and addiction lead in several organizations within our community. Okay. So today we're presenting results of a pilot study, but really we want to give the clinical context of the program, and that's why I have my co-presenters with me. So I'll just sort of breeze through some of the researchy content so we can get to the meat of the presentation. I want to acknowledge our team and the leadership at Health Sciences North as well. And just acknowledge that we have the utmost respect for Indigenous peoples in our community and the land that we operate on. I have no conflicts of interest to disclose. I want to acknowledge the Northern Ontario Academic Medicine Association for funding this project. Basically, for this presentation, this is always an issue for me. The microphone's always too high. For this presentation, we want to just give an understanding and context of the program, just give a brief overview of the methodology of the evaluation, and really just sort of give a critical reflection of what the program is from the patient perspective. So we all know the background of the situation in Ontario and BC and all over Canada with substance use disorders and overdoses. But from the Northern Ontario perspective, in Northern Ontario, we have about 10% of the population of all of Ontario and about 15% of the overdoses. And just like a lot of other communities across Canada, homelessness is increasing exponentially over the last several years. I'll just pass the mic to Jada to give a little bit of context about the situation in Sudbury, Ontario.
Hi, I'm Jada. This is just something we have downtown that's crosses for change. So all of those crosses you see are people that passed away from any kind of drug-related things. It was started by somebody's mother and her son had passed. So I mean, that picture doesn't do it justice. Like, there's so many crosses that there's no room for more crosses. So it's right in our downtown core, and it's just a place that people go and put their loved ones there.
It's also right across from the city hall, essentially. So it's front and center. Again, these slides are nothing new for anyone, but these are the presentations of people who are unhoused coming to the hospital in Sudbury, Ontario. And the last year, 2023, we only had half the data to present, so it didn't go down. And then again, just kind of building the rationale for this program. These are the revisit rates or the revisit numbers for people who are unhoused presenting to the hospital. Again, only half year of data for 2023. So in response to all these factors, I'm going to pass the mic to Dr. Leary to give a little bit of an overview of the program.
So Lotus started as an ACT program. It's a partnership between the City of Greater Sudbury and our hospital, recognizing the impact that housing status has on people's ability to be well. So as a hospital, as the Academic Health Sciences Center in the Northeast, we are lucky enough to have the portfolio that includes withdrawal management services as well as rapid access addiction management in the community. We have an inpatient unit specific for folks who are admitted to hospital who have concurrent medical and substance use presentations. And we have a roving addiction medicine consult service in hospital as well. And so the missing piece in the continuum of wellness is housing. And so it started as an ACT program. It has since been rebranded with the help of our residents to be Lotus because of the symbolism for rebirth and new beginnings. It is a transitional housing for folks who have trimorbidity, which was alluded to in the earlier presentation. So folks who have chronic homelessness, substance use concerns, and struggle with their mental health. So we are, I don't want to say limited, but our admission process is dictated by the provincial homelessness and federal homelessness funding. So folks are screened with VSPDAT, and 70% of our beds are filled with folks who come from the by names list by city referral. 30%, we have a little bit of wiggle room from the hospital. So folks who are who are admitted and have finished their acute care but have nowhere to go, we do have a little bit of wiggle room with some of the beds. We currently sit at roughly 11 beds. We are waiting for a new build that should be ready early in 2025, where we will be expanding to 40 beds. And effectively, we have brought acute services to the community to help people transition from homelessness to an ability to live sufficiently autonomously that they can be housed pending resources. So we have a team of nurses, addictions workers, peer support workers, psychiatrists, primary care, and addictions physicians who provide care in currently a repurposed motel through a combination of patient-driven individual needs and group offerings for skills development, et cetera.
So I was brought in to help conduct the evaluation because it's a new program. Wanted to make sure that we're getting evidence to support this initiative. And so these results today are just part of a larger evaluation. So we're doing some quantitative, some pre-post comparisons, intake discharge comparisons, and looking at some administrative data to track health service use for these clients. But this specific project was a pilot to test the qualitative piece of this evaluation. And so the research question was really looking at what people in the program think is important for a program like this, and what's needed, what's not needed, that sort of thing. And after looking at the data, we sort of structured the results within the confines of the Maslow's hierarchy of needs. So you'll see in the next slide with the results. All of the interviews were done by a peer, so Jada will be presenting the results. I tried to do a couple of interviews. Nobody really wanted to share anything with me, and then we brought in a peer, and the data was phenomenal. I think that's it. So I'll pass it to Jada again.
So the biggest thing when talking to the clients is that we do a housing first model. So like just making sure that they're there, comfortable, get to rest, get some food, start to build a rapport with people. Like there's no expectations on them in the first little while, just to adjust to actually living in housing again, or not like housing, but like a dwelling. So right now it's a motel. They're going to get a 1-bedroom apartment when they move. And then from there, they get, they get help with all their ID. They get put on the housing list. They get help with their finances, be it OW, ODSP. Like she said, all those people that work there are really awesome. And so yeah, they just get connected with like methadone, Suboxone, whatever, if they want OAT. She said all those things, psychiatry, all that. And we have a really great group of people there, and we've been working really well together to really make things better for the clients. So like really meeting people where they're at, and it doesn't matter if they're intoxicated and they're banned from every other program, they can still come and get the care they need at our program. So I don't know, it's working out really well, and people are being successful in the program, and the whole point is to get them into permanent housing. So yeah, I think it's working out really good, and people are actually really excelling in the program. And if they don't, like if they do stumble back, like there's no problem. You know, it's just that's what we're there for. So it's an 18-month program right now, but it's on case by case basis, really. So, anyways.
So essentially, how the data was structured, or the responses, the results were structured, was that physiological needs were the most important. So getting into housing was super important. Getting access to food, feeling safe in sort of even asking for OAT, and safe in their environment, and so sort of going up the hierarchy of needs.
So we learned a lot. We had done a lot of work on the inpatient side with the opening of our specific addictions medicine unit on harm reduction, trauma-informed care, reducing stigma, and we had a different team and a different crew who were involved in the advent of our housing initiative. And as it turns out, the work you do in one part of a hospital doesn't translate to the other parts of the hospital particularly well, even within the same service. And I think that's a really important thing. It's a really important takeaway. So we're really lucky to have research embedded in the clinical programs that we initiate and that we're operating. And super lucky to have peer support and folks with lived experience as part of that research team and clinical care team, because what we do is much better because of that. So lots of key takeaways. Like, it should come as no surprise that people can't transition from survival-based day-to-day living, and street-focused living, transactional living, and suddenly be housed and want to learn how to cook, or be able to even engage in, primary care for wound treatment, for example. So learned a lot. Low barrier doesn't necessarily mean that you can just walk in the door. It's how you're greeted when you come in the door as well. So can review some of those key recommendations, followed by those. And so that was, those are things that people learn in showing up to work every day, but it's really powerful when that feedback comes from the folks that you're there to serve, and to help build a better program, particularly as we look to amplify that from our current beds to 40 beds.
Thank you for listening. If you have any questions, we can take them now if there's any time left. If you have any specific questions about like starting a program like this, or anything like that, I put the contact information for the managers of the program. And then if you have any questions about the research or anything like that, you can contact me. Thank you.
Yes, you in the back there.
Questions about your point on safety, and I just wondered if that also came up, like how that came up in some of the research findings, like this balance of going from living on the street and having to protect oneself to how people's substance use, anger problems, mental health problems could lead to other people being unsafe. Like what did you find was that helping balance that? What were the learnings there?
We do a lot of with the life skills and the skill building that what they do like conflict resolution. So with the workers, once they build a rapport and they will actually talk to them about it, like there is things that happen like that. There is going to be violence if they're on the streets or if they're in like living in a in a regular building. So it's not consequential if that happens. It's been dealt with on case by case basis. Like I don't think that there's anybody that couldn't come back to the program for, or even getting kicked out for doing any of that. And they do value safety, but they do also have a really great rapport with all those people. So building that trust is so huge. And then, those things can get really dealt with very easily on that sense.
One of the biggest concerns that was raised from these interviews specifically, so just keeping in mind this was done about last summer, actually. So last summer.
Yeah.
About 8 months ago, I think. Anyway, but one of the things was stealing, is people weren't used to like not having to do that to survive. So that was one concern. So the life skills in the workshops and stuff like that help with that. The other piece of safety that we interpreted under that safety piece was some people didn't feel safe because they weren't able to access their medications, like their OAT. And they were just concerned about having that access, or even if they weren't able to access it on site, then they would have to go back downtown and be exposed to what they were exposed to before. So that kind of fell under that piece as well.
Do you have a follow-up question?
Yeah, I'm just curious about sexual assault and if then there was a differences between men and women in the program and if this never became at issue as well. So feeling safe would be also like a sexual sense.
Yeah, it's a great question. I mean, safety is very complex, right? And how we impose it on other people and how we feel it ourselves. Physical safety, psychological safety. And so don't have the magic bullet answer. We have not actually had to deal with sexual assault, and it's a co-ed program. So fundamentally, trust is a huge piece of allowing people to diffuse so that they don't have to protect themselves, or they don't perceive the need to protect themselves. So that the diffusion, the establishment of trust is fundamental. And I mean, that comes from having consistent program deliverables. It comes from having consistent staff. It comes from staff being on the right page when it comes to harm reduction services. So there are a lot of institutional elements that have to be met. And in addition to the interpersonal, the consequences have to be clear and they have to be consistently implemented. And we have, visitor restrictions, for example. So there's always, that's a difficult topic. Do we restrict visitors because it keeps everybody safe? But they are paying rent to live here and it is their home. And so when we have contentious issues that have no right or wrong answer, such as safety, we will always involve the folks who are living there at the time, in addition to our paid peer support workers, to try to hammer out a way forward. We'll test it, and then we check and adjust.
All right. Thank you for everybody for joining us to this topic presentation. Another round of applause for everybody.